So just some of the specific results that were pulled up as a result of the scan. It's a lot of numbers, so feel free to come ask me for questions later if you want any specific information. This table shows cervical cancer incidence from Manitoba for the years 1984 to 1997. In all age groups, Aboriginal women had higher rates of both in situ and invasive cervical cancer. So the in situ being what might be referred to as like a pre-cancer. And overall, Aboriginal women had 1.8 times the rate of in situ cancer and 3.6 times the rate of invasive cervical cancer compared to non-Aboriginal women. And this study here examined the rate ratios of cervical cancer incidence between status Indians in Ontario and the general population of Ontario in 3 different time periods between 1968 and 1991. So although overall rates of cervical cancer were decreasing in this time period, Aboriginal women continued to have higher rates of the disease than the general population. And this slide shows death rates due to cervical cancer between 1953 and 1984 in 3 different time periods, and shows that although the rates were decreasing, the death rates were decreasing in both Aboriginal and non-Aboriginal women, that it was still higher in Aboriginal women. So some results for cervical cancer screening, or more commonly referred to as PAP screening or PAP testing. What we have found is that rates of cervical cancer screening have improved over time in all populations, and that uptake in Aboriginal women is similar to that than their non-Aboriginal peers. And this high uptake of screening should translate to even further decreases in cervical cancer rates. So some of the specific results, showing data from NAHO. They reported from a pan-Canadian telephone survey in 2002 that only 50% of on-reserve First Nations women aged 18 to 69 years of age had received a PAP test within the past 3 years, which is according to standard guidelines. However, the First Nations Regional Longitudinal Health Survey of 2002-2003 reported that overall First Nations women reported levels of cervical screening comparable to the rest of Canada at 76%. And these results from the Canadian Community Health Survey between 2000 and 2003 show that 85% of Aboriginal women had had a PAP test in the previous 3 years, which is quite high, and with respect to other ethnic groups that were surveyed, it's also on par with Caucasian women that were surveyed during this same time period. So results for HPV infection. Because the science on HPV is relatively new, there are a few studies published on the rate of infection in First Nations, Inuit and Métis populations, but the results indicate that the rates of at least some HPV types may be higher than in non-Aboriginal women. So this table is from a study done at an inner-city health clinic in Manitoba between 1992 and 1995. And it compares results between First Nations and Métis women with non-Aboriginal women. So the data show that although there was no significant difference in HPV infection rates overall between these 2 groups, out of the 4 vaccine-preventable types, so it's HPV 16 and 18, the high-risk types, and HPV 6 and 11, which are the low-risk, HPV 11 and HPV 18 were more prevalent in the Aboriginal group. And Dr. Sobel presented a bit of this work in his introduction. This is Sylvia Healy's work from 1999. And she showed that the prevalence of oncogenic or high-risk HPV was over 25% overall. But there is no significant difference in infection rates between Inuit and non-Inuit women. However, there was a suggestion that in the Inuit women, they may acquire HPV infection at a younger age because the rates in the 13 to 20-year-old age group were quite different, with the rate being 31.7% in Inuit participants compared to 11.8% in the non-Inuit. And the prevalence of a high-grade abnormality on the Pap test was 0.3% in the Nunavut population, which is similar to that in non-Aboriginal Canadian population. And just to compare, studies from Newfoundland and Ontario in the general population show that the prevalence of HPV was in the range of 9 to 13%. So in this study among Inuit women in northern Quebec between 2002 and 2007, HPV rates were higher than those seen in studies among non-Inuit populations, with a 20% prevalence of high-risk HPV. And rates were highest amongst the youngest age group, which is similar to what we see in other studies. And the prevalence steadily declines with age until it reaches a low in the 40 to 49 age group, and then it begins to increase slightly, so you're seeing that U-shaped curve in the graph. And again, this is just reiterating the study that Dr. Sobel presented earlier today. I just want to reiterate the fact that although there were some differences in HPV rates, it was very type dependent. So while HPV 16, which is the most common type, there's really no difference between the Inuit and non-Aboriginal women in the territory with respect to their prevalence of this infection. The main difference was in type 31, which, as Dr. Sobel mentioned, is really not very commonly seen outside of the north and outside of Inuit populations. We're not sure why, but it's certainly an interesting finding. So to summarize, evidence suggests that First Nations, Inuit, and Métis women bear a higher burden of HPV and cervical cancer than non-Aboriginal women. Pap screening uptake is high, and it should result in further reductions in cervical cancer rates. And more studies are required to fully understand the impact of HPV and its consequences in First Nations, Inuit, and Métis populations so that we can inform prevention strategies. And then just a few discussion points, a little bit of food for thought. We have seen studies demonstrate high rates of Pap screening in First Nations, Inuit, and Métis populations, but we have some evidence that access isn't the same across all communities. So how can we optimize Pap screening uptake in remote and isolated communities? One possible solution that has been brought up or suggested is to introduce self-sampling, where women would take their own swabs and then send them off to a lab to be tested and then be mailed back the results. There has also been some discussion of introducing HPV testing into cervical cancer screening programs, as Dr. Sobel was mentioning in his presentation. So what is the best way to approach this, and how can healthcare providers communicate results to their patients in a culturally appropriate way? And finally, we now have 2 HPV vaccines available in Canada, and all jurisdictions across Canada are implementing immunization programs. So how can these immunization programs be optimized for First Nations, Inuit, and Métis communities and delivered in a culturally appropriate manner? So just with those questions, just like to thank you for your time and for this afternoon and for the opportunity to present. So good afternoon.